Good afternoon or good morning, depending on what time zone you are in, and welcome to the 2022 Open Summit, Day 3, brought to you by the Ontario Pharmacy Evidence Network and the Centre for Practice Excellence at the Faculty of Pharmacy at the University of Toronto. My name is Zubin Austin, and it is my pleasure to be introducing today's summit. I'd like to thank Annalise, Research Officer at the University of Toronto, who is going to be hosting today's summit, and who of course has also been the organizing force of nature behind not only today's event, but all of our other events. You'll be meeting Annalise shortly as our program begins. Before beginning, I would like to acknowledge that I am on the traditional territory of many nations, including the Mississaugas, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And this land continues to be home to diverse First Nations, Inuit, and Métis peoples. I recognize that you joining us today may be on different territories and invite you to consider and provide your own acknowledgements of the ancestry of the land and the commitments made to those peoples. As you are all aware, I hope, OPEN is a team of multidisciplinary researchers, and we have been working together to evaluate the quality, outcomes, and value of medication management services that pharmacists and other healthcare professionals provide. Part of OPEN's mandate is to foster knowledge translation and exchange and to help build capacity in medication management research. And that's one of the objectives of today's summit. As our tagline suggests, we are all here to learn, to collaborate, and to share. So thank you for joining us. The Centre for Practice Excellence is a co-host for today's event. CPE is located at the Leslie Dan Faculty of Pharmacy, and we're involved in the generation and utilization of leading-edge medication management research and innovation. We host monthly speakers series, occasional symposia, and a variety of other exciting initiatives designed to bring together practitioners, researchers, staff, students, and professionals from around the world to serve as a network. We hope you'll be able to join us at future CPE events, and if you are not already part of our CPE community and receiving our emails and newsletters, please consider joining so you can keep up to date with our activities. Today is the third of our four-part Open Summit, and our focus for today is going to be on hearing what patients need and how pharmacists are responding. Please note that today's event will be audio and video recorded. These recordings will be available on the Open website shortly after the event. If you've attended any of our previous summits, you will know that we have moderated questions and answer periods, and we'd invite you to actively and prolifically use the chat box feature in Zoom so you can interact with one another, with our speakers, and start to build a community of interested individuals who will be here to learn, to collaborate, and to share. The aim of today's summit is to disseminate and share knowledge generated through research. We do ask all of you, however, and all participants to recognize that some of the research being presented today is still in progress, and we ask that you refrain from sharing any specific results and data, including through your social media. Beyond that, though, we would encourage you to Twitter, to use whatever social media you would like to promote today's events, and to highlight some of the general discussions that we are having. I'll now turn it over to our host and moderator for the Open Summit today, Annalise, to introduce our keynote speakers. Enjoy the day, and I'm looking forward to learning, collaborating, and sharing with all of you.
Thank you so much, Zubin. And I'm just going to take my slides down. Welcome everyone to the event. I'll be introducing our keynote presenters today, ZAHAVA and John. Huge pleasure to have them both here today, and I think it will probably stimulate lots of discussion. So ZAHAVA, I'll let you put the slides up and just introduce both of you. So ZAHAVA ROSENBERG-YUNGER has worked in health services research for over a decade within not-for-profit and academic settings. She's an adjunct professor within the School of Health Services Management at Toronto Metropolitan University and works at Trillium Health Partners as a research associate at the third level. Her research interests include pharmacy practice, equity, resources allocation, comparative health policy, and stakeholder engagement. Thanks, ZAHAVA. Pleasure to have you here today. I'd also like to introduce John Jones. John is currently the Assistant Director of Finance and Operations with McMaster University's Continuing Education Department. Prior to this role, John was the Chief Operating Officer for the Ontario Association of Medical Radiation Sciences, the Associate Dean of Business and Campus Principal at Sheridan College, and the Director of Management Accounting with the Chartered Professional Accountants of Ontario. He holds a CPA CMA designation, an MBA from Wilfrid Laurier University, and a BA in psychology from York University. He's passionate about education, training, and lifelong learning, and values collaboration in the pursuit of everyone's success. Thanks so much for joining us today, ZAHAVA and John. I'll let you take it from here.
Great, thank you, Annalise. I just want to confirm that you can see my slides and it's not in presenter view, it should be go on. Yeah?
Looks great.
Wonderful. So good afternoon or good morning. Thank you so much for inviting John and I to present. We're really excited to have this opportunity to start off today's session, hearing what patients need and how pharmacists are responding. We were asked to present on Open Citizens Council. Do we really need another acronym in healthcare? And so that's the title of our presentation. And just to say that when I began working in this area of stakeholder involvement over a decade ago, there was a view that patient experiences were not or should not be prioritized in healthcare decision-making. And I'm really happy to see that is no longer the consensus. And so John and I are really thrilled to be here today to talk to you about our journey putting together the Citizens Council, why we decided to move forward with the council, what gaps it fills, and some lessons learned along the way in our journey of working and putting together this council. And for some reason, my slides are not progressing. Okay. Sorry. I'm not sure why that's happening. Okay. I'd just like to take a moment to acknowledge our teams, the council members, and our funding. So this work of the council would not be made possible without our program manager, Mansour, and of course the support from Open Executive, which includes Nancy Waite and Lisa Dolovich, who incidentally are also the co-PIs of the CIHR Planning and Dissemination Grant, which is one of the funding agencies which funds this work, as well as Sherilyn Hull and Lisa McCarthy. Oh, what is happening? Why are my slides progressing? I am so sorry. This should not be happening. Okay. Again, I just wanted to acknowledge the members of the council for all their work to date and their collaboration. Disclosure statement. So John and I have nothing to disclose today. And we're going to move to the outline. Okay, so today, John and I will take you on the journey which we went to put together the Citizens Council. And before I get started, I just wanted to draw your attention to two things. John and I will be referring today throughout our presentation to a number of resources that we used to put together our council. And I think if they haven't been shared already, Annalise will share them with you afterwards. So I don't want you to be worried about scrambling to write these resources down. They will be given to you. Additionally, I just wanted to draw your attention to the fact that Open has a website, and on their website, there is a tab with information on the Citizens Council, including a list of its members and the terms of reference. So today we're going to be talking about starting off with the gap in which we thought the council was addressing when we decided to move forward. We'll follow this by looking back and seeing where have we gone? What happened until this point that we are now? And then we'll talk about the vision and purpose of our council, how we originated, and we'll spend some time on the importance of evaluation and building in evaluation components throughout whatever types of initiatives involving stakeholders. And I don't know why this is doing this, whatever stakeholders you're involving. Towards the conclusion of this presentation, we'll talk about some of the lessons we learned, and then finally we'll wrap it up and look at some of these amazing talks that we have following our presentation today. So let's start off with the gap. So when we first started off, there was no formal and ongoing way to engage community and harness their collective wisdom within Open. And so what we wanted to start off with, the rationale for putting together the council, was really to uphold principles of democracy, and through that to include, to facilitate the inclusion of the values and priorities of the citizens which we serve. However, the challenge we faced was, if you're familiar with the literature in this area, that there is really inconsistent language. And you'll note throughout this presentation, we sometimes say involvement, engagement, citizens, public, patients. So all these different words. And that makes it very hard to pinpoint what kind of initiative you want to have, how are you going to frame it? And that's really important. What I can say is, even with these varying terminologies and definitions, is that we knew that there was a common theme, and that was that we really wanted to strengthen and facilitate the role of end users in open. So let's look back. So open began in 2013, and from its inception, patients were really a critical part of the work they were doing. But it was only in 2018 that they decided to formalize and put together a strategy, a patient and public engagement strategy. And from this strategy emerged the need to put together a council. We subsequently had our first meeting back in 2019. At the time, it was called a Citizens Panel. We subsequently renamed it based on comments from our members to the Citizens Council. And you'll see through this timeline that we've had a total of 5 meetings since 2019. And actually, we have a 6th coming up in about a week from now. You'll notice also in 2021, we had a second recruitment drive, and this was because of attrition. So over the years, we lost members, and we needed to gain membership. And so right now, after that second recruitment drive, we have a total of 16 members. So what can I tell you about these 5 meetings? We've had a total of 8 researchers present over these 5 meetings. And when I ask researchers, how have they used the work of the council? Like, how has that impacted their research, or how has it changed what they're doing? And I'm going to share with you today some of those comments. So one thing is, we know that some of the researchers that presented ended up refining their existing questions and even adding new questions to the research they were doing. And this could be either to the overall research question, or even to if they were doing surveys or the key informant interviews. So changing those aspects of their research. Researchers also modified their existing recruitment strategies. And what they found was most helpful was just gaining overall citizen perspective to their work. So when we started off on this journey, our vision was really one to ensure diversity. And we took a look at Health Quality Ontario's Recruiting for Diversity document. So they're no longer Health Quality Ontario, now they're Ontario Health, but they put together a document. And in that document, one of the things they talked about was consider how to remove barriers. So I'm going to give you one example that we thought about when we started off in 2019. We decided that we were going to do in-person meetings. And at the time, we thought that we could include people that didn't have internet or computers, which would allow us to include more people, more diversified people. But subsequently, as you know, we had to pivot because of COVID. And so during our second recruitment drive, we actually changed that and said, no, we have to limit it. We made a conscious decision to say, we're going to only allow people that have internet access because we were limited because of COVID. So I think what the lesson learned here is really important, that when you're moving forward with an initiative, you have to be very conscious of the choices you make and how it may or may not affect diversity of your membership. The other thing that was really clear for us was that we wanted to ensure we secured some kind of funding for our members to allow them to participate. And so we were successful in getting the CIHR dissemination grants and also have support through Open. So that was really important to us. The other thing was we wanted to listen to our members' needs. And we didn't want to be overly prescriptive in what the council would look like. And so while there were certain boundaries that we had to adhere to, for example, Open is a pharmacist research body. So we were limited in that we wanted the council to give advice around pharmacy specific types of research. We really wanted the specific objectives to come from the bottom up from our members. And hopefully by doing that, we were hoping to build and foster a partnership, and that would be based on trust. And so this might be a very familiar slide to some of you. There are many different iterations of it, but this is about different levels of involvement. This particular diagram comes from CIHR. And I just feel like as we moved into the operationalization of the council, this is something we kept in the back of our minds, understanding what type of level of involvement we wanted from our members. And so when we look at this, if you look at the level 1, which is the lowest level of involvement, which is communication or informing and educating, we knew we wanted to go beyond that level 1. And really what we're striving for is to move towards level 5, which is really partnering, in which our members have the ability, a high level of involvement and the ability to influence things that are happening within the council. So thank you so much. I am going to now stop my slide share, and John is going to share his slides with you now. So bear with me for one moment. Thank you.
Can you see my screen okay? Slideshow? Okay. Thank you, ZAHAVA. It's hard to believe it was February 2019. It went by so fast, but thank you all for allowing us to present, and it's my pleasure to continue on from where ZAHAVA left off. So with respect to the purpose, the team actually created terms of reference with all the members. It was a very iterative approach, and it took many meetings, probably about 3 or 4 overall, which all the members contributed equally, and I think felt like they were valued. We used Health Ontario's creating an effective terms of reference as a guide when we drafted this statement, which is provide feedback on and ideas for pharmacy practice research and opens overall strategic plan using patient-centered approach, advanced patient engagement, patient-centered care principles and practices that open. And just to make it clear, the slides I'll be referencing here from that point will be from the perspective of a member. So our origin, as ZAHAVA mentioned, we originally had 12 members. So it was part of the original 12, of which there's 6 remaining, which I think, is probably a statement to COVID and those sorts of things, but also I think anytime there's probably a normal amount of attrition that takes place. In terms of the characteristics of our group, you can see here, female is 62%, male is 38%. Interesting, the GTA is 63%, and Kitchener-Waterloo is 38%, and this was more a function of the funding that ZAHAVA mentioned before, in terms of how much we could actually afford to bring people in place and bring people to, either GTA or Kitchener-Waterloo or sort of thing. From a background perspective, European 50%, Black, Asian, and Chinese are on the team. We have a nice distribution across ages here. You can see same thing with university, and then when it comes to religion, it's mainly no affiliation, about 44%, with Catholic at 25, Hinduism at 19, and Islam at 6, and Judaism at 6. So it's a very, very diverse group. It was interesting to get to meet everyone and get to understand where they're coming from and what perspective they bring to the group itself. So how do we work as a group or as a team? It is a very collaborative, consultative, and responsive process. As you can see from the pop-outs here, these are taken from evaluations from the committee members after each meeting. So as you can see, when it comes from a collaborative, consultative perspective, it's more dynamic and an interactive platform for the council to educate themselves and just further discuss. So this is a request from one of the committee members. And due to that, ZAHAVA and NSERT actually created a Teams group, which allowed for a forum for individuals to meet before and afterwards, sharing of documents, and really for the committee members to stay more engaged. From a knowledge exchange perspective, in addition to the members' meetings, we have access to the Teams, our research folder, which is actually a channel on Teams. And there's many options for communication, allows participation, addressing the various needs. Again, the pop-ups are specific quotes from members themselves. And then lastly, one of the things that actually came through very clearly in the actual evaluation themselves was recognition and value of the members' time. So meetings are planned well in advance, scheduled based on a consensus basis, and so forth. Members are offered $125 honorarium for attending meetings and completing required training. And if a member chooses to participate in the post-meeting evaluation, they're offered a $20 gift card. So these are sort of how things are right now, how things work, and it's evolved over time. Some things were definitely set up in advance, such as the honorarium, those sorts of things. But it's nice to see that throughout the process, ZAHAVA and then so we're able to adjust according to what was deemed important to the community itself. So evaluations are very, very important, obviously, and both formal and informal ones. So formal ones, all members and researchers at the end of each meeting are asked to complete public and patient engagement evaluation tool. All researchers are asked to participate in an interview as well. And then at the end of the full funding period, all members will be asked to participate in an interview itself. And then informally, members are asked following the conclusion of each meeting, what can we do to make this experience better for you? And in fact, I think one of the findings, ZAHAVA can speak to this if you'd like to add or anything, but was that informal evaluations are very, very important. You get the most important sort of gut sort of feelings from individuals right after that meeting rather than filling out a form afterwards. So top lessons learned. So these are pop-outs, again, quotes. So my experience as a patient and caregiver are valued and taken into account for research and policy purposes. There's definitely a difference between hearing and listening. And it's something that came through clearly at the very beginning of this group's sort of evolution, that they wanted to know, are we being heard? Are people listening to us? Are they, what is the impact that we are making? Is it valuable what we're saying? Because most people around the community, the members themselves, aren't part of an education research area. They're not sure what sort of opinions matter, which ones don't in the beginning. And so to that, engagement can be messy. It takes time to get it right. So plan ahead, I guess, plan that it's going to take longer than you expect. I mean, I came to this group using a business lens, and it's a volunteer lens. And I would get somewhat frustrated at times if I felt that, individuals may not have come to the meeting prepared or they didn't actually contribute in the way I thought they would. But it took me some time to realize, okay, these are volunteers, these are not employees. So, take time, give them all time to get to evolve and figure out where their comfort level is. So again, ensure there's a feedback mechanism, and as you can see, there's a request for if we kindly get feedback about our views are used to influence the work the organization does, it would be helpful. Going back to, is it valuable what we're doing here? And then lastly, evaluation, especially informal, is critical here. So we started off this talk with where we've been, and today we celebrate about where we are now. And we hope to leave today after the next set of presentations today with where we're going with respect to applying a patient-centered lens in healthcare across the system. Thank you, and I'll pass it back to ZAHAVA.
Thanks, John. So we'll be happy to entertain any questions now. So I don't know, Annalise, will you be moderating the question session?
Yeah, thank you. Thank you both so much for your remarks and presentation. I can see a question already in the chat from Suzanne, so maybe we'll get started with that. I'll just read out the question. She asks, was your group truly diverse? Most were white with university education and likely had a level of privilege to be able to participate in the group. This is something we struggle with at my clinic's patient advisory committee. How to define diversity, how to recruit with a commitment to EDI. I think these are big overarching questions that you probably don't have all the answers to, but if you'd like
it's an excellent question, and it's something we have also struggled with. Is it perfectly diverse? No, I'm not sure we were able to get there. I think we tried. I think we did try techniques to increase the diversity. But I think you're right in that generally people that have time to volunteer or to even only receive $125 for a 3-hour meeting are people coming from a background of privilege. And so I think when anybody, myself or anybody, decides to move forward on this type of path to involve people to get their opinions, it's really important. I'm going to go back to like the payment, the funding. So when we're applying for grants, we have to really build that in and build in enough of a budget that we can expand our population and really try and get a more diverse pool. John, do you want to add anything to that?
Yeah, no, I totally agree. I mean, I think the challenge partway through was that we realized it wasn't necessarily diverse. I mean, especially when you look at the two catchment areas that we're trying to build from, the GTA and then Kitchener-Waterloo, and most people came from the GTA. And early on, we realized we tried to get more, but I think COVID sort of gave us a little bit of a turn as well, and so we are where we are, but we're much better off now, I think.
Thank you both for those remarks. Maybe quick question sort of along those lines. I know the pandemic has also brought up, I think, an increasing amount of polarization on certain, I'll say, issues that are relevant to citizens and people in general, also obviously including patients. How can we manage that sort of, or do you have any lessons learned or tips for managing perhaps polarized opinions or perspectives that might come up in a citizens council, and making sure that both sides of that polarization are balanced?
That's a really great question, and not necessarily COVID specific. Maybe we just feel it more now because of COVID, but I think anybody who works in the space of any type of stakeholder involvement or facilitation knows that can have part of being a good facilitator is being able to ensure that different voices are heard and different perspectives are heard, and that there are different avenues for them to express their opinions. And so one of the things we've done is we've told our members that if something happens that they don't feel comfortable commenting on within the group, that they should feel welcome to approach any of us, any of the staff, so myself or Mansour or John, individually through email or phone, or even Elisa and Nancy if they feel more comfortable. So we've opened it up in that way, and we've also allowed them to be in touch over the Microsoft Teams option. So we've just tried to enable different types of communication to allow for different people's comfort levels. So that's one thing. And then the other thing is that actively at meetings, there has to be someone who's responsible, who takes accountability and ensure that each person has an ability to voice their opinion in a non-judgmental kind of environment, right? And so that person has to be ready to step up and step in when necessary.
I would just add, I think it also evolved over time. So at the beginning, the group was very careful not to, I would say, actively disagree with individuals. So if someone had an opinion first, it was like, oh yeah, that's a good idea. Let's go with that. And then I think over time, everyone became comfortable with it. Yeah, we can have different opinions about how things should be done, can be done, or different opinions of what we think, and there's value in that. And once the team came to that conclusion, people shared more freely.
Thank you both so much. I think it's something that, I totally agree with ZAHAVA. I think existed prior to the pandemic, but probably is at the forefront of many of our minds right now. I have placed all of your resources into the chat, probably have overwhelmed lots of people online, but hopefully those will be valuable. I think it's really nice to have the opportunity to share so many great resources like this that are really intimately linked with your presentation content. I think that's something a bit new for the summit, is just really sharing resources like this. So that's fantastic. Thank you. Curious if there are any other questions or comments from our audience. Happy to take those, or if you would like to follow up with ZAHAVA or John privately in the chat, that's fine as well. I'll just open it up for a few more seconds and see.
While we're waiting, I'll just say one thing. So I was just conscious of the time as we were going through, but I did want to mention that in addition to looking at the literature when we put together our strategy and tried to put together the council, we also reached out to various hospitals that have patient advisory committees to ask them kind of like to give us advice how they did it. And those of us working in the academic environment know, like, if you do a literature search on how to put together a council, there really isn't much out there, right? They'll talk about, engagement and how to make people feel listened to and all that, those techniques, but not actually practically how to do it from the ground up. And so those conversations were really helpful. And so I would encourage anybody who's thinking about going down this route to reach out to people who've done this type of initiative in the past, and because they can offer some really great tidbits on how to move forward.
Thank you, Zahava. I think that is very important and kind of ties into just wanting to use this summit as an information sharing mechanism, and perhaps like Suzanne online as well, building together communities and pockets that are working with citizens, working with patients, and drawing together those lessons learned. I think that's absolutely critical. Any other last thoughts, John, Zahava?
Just to say, I'm really excited. This lineup today is really great. And I think it really shows how pharmacy is evolving, which is wonderful. We're going to see some presentations that speak about using like a patient lens within the policy frame, and also all the way to like the micro kind of interaction, pharmacist patient interaction. So I think there's lots of opportunity for pharmacists, pharmacy students, researchers to really apply a patient-centered focus and lens to whatever they're doing, whether it's designing research, creating policy, or just interacting with patients. I think there's lots of opportunity for us to learn from one another and to move forward. So really looking forward, excited.
On behalf of the committee members, I just want to thank Zahava and Answer for everything they do to help keep the group going. It's a very fun, collaborative experience, and it's mainly due to a lot of the work that they do. So thank you.
Fantastic. Thank you both. Really, really grateful to hear your remarks. And I think there'll be opportunities for a bit more sharing in our kind of discussion circles that take place at the end of the event, where we have a nice cross section of perspectives from people in smaller breakout rooms. So thank you both so much. I'd like to turn us now to our first research presentation of the day. So if you've joined us for other summit events, we have a series of 4 research presentations for each day. The first presenter that is joining us today is Stephanie Ong. I will let you put your slides up on the screen. Stephanie, great to see you. And I'll just introduce you while you're getting set up. So Stephanie holds a pharmacy degree from the University of Toronto and a graduate degree in health informatics from the University of Victoria. Her expertise and main research interests lie with implementing digital health applications to promote integrated health delivery models in patients with chronic disease and enhance the patient's medication management experience. Stephanie presently is a clinical pharmacist in nephrology with the University Health Network and a project manager with UHN Connected Care's regional and provincial digital health programs here in Toronto. Stephanie, thanks for joining us, and I'll pass it over to you.
Thanks so much, Annalise, and for the group, and for having me today to share experiences. I learned so much from the first 2 speakers, and I hope I'll be able to share experience too with you this afternoon. Just wondering if I have the slides up and you can see them.
Yep, they're up. If you want to put it in presenter mode, we're still seeing the screen with sort of as it would show up on a normal PowerPoint.
How's this?
Just give it a moment. I can see, I think your mouse circling maybe. I think it's still in that format. I'm not sure.
Okay, let me just try again.
Yeah, you can close and set it up again. I've been having my own technological issues this morning and this afternoon, so
I know. I'm like,
it goes on and
do
on.
I pick? Let's see. And does that help?
Yes, this looks great. You're just on the disclosure statement.
Here we go. I'm going to whip through this with my disclosure. I have nothing to disclose. And for today, so I have my objective slides. Is that right, Annalise?
Yep, we're good to go.
We're good to go. Okay, all right. So in this segment, what I hope to do is describe to the group the integrated model of care that we've applied in kidney disease and how it's been targeted to really address medication-related problems, but also would like to present and describe to you how we've implemented virtual pharmacy to address some of the key medication outcomes in this high-risk population. But also I'd like to finish off with discussing some of the key implications in practice and significance on how we can then implement this integrated care model in future practice. So to begin, as we know, patients just like the ones with complex chronic kidney disease are at high risk for medication-related problems. It is the top 5 leading cause of death in our population. As they see multiple physicians, they go to a lot of different appointments and healthcare settings, so that's really high risk. It's a huge burden for our healthcare system, with amounting to about 175,000 ED visits across Canada per year. And from the patient's perspective, a lot of these adverse drug events that happen in ambulatory care really lie with regards to the communication between providers or the lack thereof, or between the patient and the provider not being able to communicate properly. A lot of our patients also experience poor medication outcomes because they don't even get to the pharmacy or go to the pharmacy to pick up their new prescriptions. Up to 30% of them never fill their initial drugs. And it has been reported that in 1 in 5 Canadian households will not fill their prescriptions due to a lack of drug insurance. So as a team in the nephrology clinics, we continuously search for different types of models of care to really address these medication-related burdens. And what we've come across in the past few years is integrated care. And it really embodies many different types of definitions. But the one that I've highlighted for you this afternoon, we've derived and adapted from the WHO and from 2002. And it really emphasizes a coherent set of methods or processes that targets coordination and collaboration, but it also cuts through multiple healthcare settings and also providers. So it's not just through pharmacy, but through all those different types of providers and healthcare settings. There has been evidence to show that in other disease states like COPD, surgery, and diabetes and elder care, it has been proven to decrease lengths of stay, readmission rates, and also improve patient and provider experience. However, there is a paucity of evidence to actually target these models to improve medication outcomes or to address them. But what we've learned so far is that if we apply some of the principles of it, of coordination and collaboration, we can target the root causes of medication-related problems and address the gaps that's really causing them. So the principles or the guiding principles that were really founded of what formed the virtual pharmacy model in the nephrology clinics were adapted from these definitions, but also from other programs such as the St. Joe's Hamilton program. And it carries this one principle. So the first part of the principle is the one team concept. And what this means is that not only all clinicians are part of one team, so physicians, pharmacists in the community, and also allied health members, but the patient is also part of the team. And there is a shared accountability and defined roles with all the team members, including the patients. So the patient and the providers co-develop the process, including the forms, the documentations, the types of activities, and there is an understanding what the roles and responsibilities are. There is also one record or documentation. So there is an intentional redesign of documents or shared records that all the information will reside and how they will be transferred to each other. So in this particular case, because it is a pharmacy related, then the prescription itself and the documentation tool we set out to redesign. And I'll show you a sample of that later. There is also one contact information, whether it's by email or by phone number. So we share one shared inbox for email and also phone number, which I will let you know and describe more in a bit. And finally, there is a standard of practice for this therapeutic pathway or clinical pathway that is supported by evidence-based so that it is both efficient and effective. And it is again agreed upon by this interdisciplinary team and with the patient. So all the activities are based on this agreed upon standard of practice. All this is supported by the virtual care services, so it doesn't lie on our traditional brick and mortar like clinics or even pharmacies. So we really try to harness simple yet accessible digital health tools such as email, the phone, e-fax, so not your regular fax machine, or digital prescriptions and digital signatures. So we want to make sure that all the tools that we have really are accessible to anybody in the population. These are the details of the virtual pharmacy pathway. It starts with the prescription being written for the patient for target medications. The pharmacist then receives it digitally through e-fax, then confirms receipt with the clinical team for any type of initial problems, contacts the patient for any reviews, full medication history, education about the drug, reimbursement investigation, and then agrees with the patient on a follow-up plan on what the patient follows up with and the monitoring plan, and when the pharmacist gets in touch with them and what activities need to be done. The prescription then gets delivered directly to the patient within 1 or 2 days, and then a monitoring plan then gets set in place. So the first monitoring time will be 1 week after the prescription starts, where the pharmacist checks in for adherence. Are they taking it? How are they taking it? Any side effects to report, and any types of clinical changes that has happened so far. We don't expect any clinical changes at this time because most of these medications are chronic, but they just want to check in. Then we collect and collaborate with the physicians and the physician team to basically provide a status report on the patient and any type of interventions that need to be relayed. So it is not like an FYI connection, but it's actually actionable items. Then another type of follow-up is set in place 1 month after starting the medication and then 3 months after. Again, to check up on the adherence for the medications and also side effects. And now we focus on clinical change. So changes in your blood pressure, changes in blood sugars, and also any type of improvements in clinical outcomes. This particular calendar highlights all the events that really outlines who is accountable and when it's going to occur. And there's ownership and also a detail on when the patient can expect the pharmacist is going to call, when the connections are going to be made to the clinical team. So we all know, whether the physician, the patient, or the pharmacist knows when these activities are going to happen. This is the sample prescription of what a standardized prescription would look like and referral form. So the medication list is included. The indication and also the monitoring plan for that drug will be included, and it's specific for the drug, and what specific patient supports are required that needs to be added in order for the patient to push through. So the nephrology program implemented this in our target patient population with complex diabetes, onconephrology, and also glomerulonephritis. And we only targeted specific drugs that were new starts. So SGLT2s, GLP-1s, avulizumab, and when the physician deemed that the patient was high risk for non-adherence. In a 12-month period from February 1st, 2021 to early February 2022, we had about 60 patients that were enrolled and referred into this program. They had an average age of 72. And also an average number of medications of 10.5. And this is what we saw when we actually just looked at medication-related outcomes. So in terms of access, 36 out of the 60 patients had some form of issue with medication reimbursement. So drug coverage or not being able to afford it. And 33 out of the 60 actually had improved reimbursement. So we were able to solve it, investigate it, and find them other forms of alternative coverage. So they were able to access their drugs. With respect to adherence, 91% of our patients were able to fill the prescription within 2 days, with the remaining 9% chose not to start their drugs because of their own preference, so they were not ready to start. In terms of identification of adverse events after baseline calls or follow-up calls, there are over 2,000 calls between baseline to follow-up to emails between pharmacists to clinicians. And with those 2,000, a total of 208 issues were identified during that time, where an intervention was necessary in order to circumvent any other further serious side effects for the patient. So approximately 1 in 10 issues were really identified and averted and intervened on. When we broke it down to clinical significance, about 53% of them were mild, so there was no direct patient harm or additional follow-up that was required or blood work, but monitoring was needed to ensure no further harm was done to the patient. Another half of them were about moderate, so there was some intervention that was necessary, whether it was withholding the drug or dose titration, in order to prevent any type of acute or chronic complications. So examples of these are like dose titrating the GLP-1s and prolonging the titration period because of severe like GI side effects, or holding SGLT2s because of acute kidney injury due to radiation treatment whenever they had like treatment due to our cancer. We did have some cases that were severe, so intervention was required to prevent an ER visit or hospitalization. And some examples of these were full-blown allergic reaction to SGLT2, or even taking NSAIDs because of a gout attack because of the SGLT2s. So other outcomes that we found were resource related, where it really only took the pharmacist 20 minutes to call the patient, even though there were numerous calls or emails between all the team members. And even though we didn't do a full-blown cost analysis, what we found was when we took the average cost or financial impact of these issues, it actually averted approximately $200 of downstream cost savings due to these interventions. And when we look at the experience of patients, caregivers, and clinicians, 98% anecdotally said that they were satisfied with being enrolled in the program. The rest of the 2% wanted to be referred back to their regular pharmacy, as this is what they were comfortable with from the beginning. I want to share with you some of the quotes from patients and caregivers, including providers. And the benefits that they highlighted is that the patients felt that now the pharmacists were kept in the loop and were part of the circle of care with the clinical team. And physicians felt that the communication and standardized monitoring were seen as a resource-efficient manner to really intervene early, and they had key actionable items of what they would do with that patient. So in conclusion, in this integrated care model, I hope I was able to share with you how we were able to really target medication-related outcomes in these high-risk population and be able to use an intentional redesign of pharmacy processes and documentation to support this model, but also harness digital health tools. We are applying this model in other programs, such as our COVID care pathway at UHN and supporting our Paxlovid regional distribution. And we're hoping to share that in future meetings with you later. And thank you for your time.
Fantastic. Thank you so much, Stephanie, for introducing us to that program. And nice to know that there are plans to scale as well. I think that's always quite important. A few questions in the chat already for you, so maybe I'll just turn right to those. Similar sort of question from Suzanne and Kay. How come the pharmacist is not involved before the medication is prescribed? Any thoughts to flipping the order of the pharmacist's involvement to be before? And kind of along those lines, is it perhaps more prescription-centered rather than patient-centered? Would love to get your thoughts on that.
So that's a very good question. The pharmacists that were involved were part of the community. So if we think about our regular process, prescribers are in the institution while a community pharmacists are in their typical dispensing area, right? So while we were redesigning the process, we really tried to do the first interlock between them and put them at the prescribing. If we put them right at the beginning, it was seen as very disruptive through the dispensing process where they're getting pulled too far away from their traditional model. So it might be the next step of really bringing them into that holistic model of care, but you're right, they should be right there with you at the prescriber's level. So this particular pharmacist role is really the frontline dispensary at your retail pharmacist, but just looking at this virtual space, not your typical ambulatory role where they sit in the clinic with the prescribers.
Great, thank you, Stephanie. Hopefully that's 2 questions answered in one. I'll pose Greg's question next. Does your protocol include circumstances when the patient must attend the pharmacy? In other words, is there ever a need for in-person care?
So when we first thought about this happened even before COVID. So the restrictions were not there. And when it was full-blown implemented due to the COVID restrictions, then the need for virtual became even more heightened. But in the times when there is in-person requirements, they would come into the clinic area. So to see the physician, do a physical assessment, but to see the pharmacist, there was no brick and mortar. Then the medication still needed to be delivered. And the actual seeing was just done by video or by telephone. So there was the seeing component of a physician and physical assessment, but there were never circumstances that we had an in-person pharmacy requirement. But there were no real requirements to actually see the pharmacist because there was always the provision of delivering this drug. The patient never had to go to a physical location to pick anything up. That was also a change in mindset for the patient because the knee-jerk reaction is a patient felt like they need to go to a building or physical space to see the pharmacist. But we all said you don't have to. And there was never a thought that there was a requirement, and there was never an ask either for that. Yeah.
Great, thank you. Yeah, I think, COVID has shifted some things, and I think we're definitely seeing the rise of a lot more programs that are taking place virtually. But yeah, I think depending on the program, very important to have both components in place depending on what specifically is being done.
Yeah. However, maybe I can follow up with that though, as these are first 60 patients. We will start to see patients who need some more support in terms of educating them about devices. So sometimes patients don't have access to video calls or even video to watch it. And that's where I would see the need for an in-person assessment, and we'd have to build that into the system of how that will be done.
Okay, great. Thank you so much, Stephanie. Any other questions from folks online? Please feel free to follow up with Stephanie directly in the chat. One more question from Greg. I will pose this just because we do have a few more minutes. Are we to conclude then that there are not clinical indications or reasons for a patient to see the pharmacist in person for this program?
So I think for this program, so just to highlight that it was for new starts for specific medications and specific target populations. So there was no clinical reason to see them in person, you're right. And like I said, if there are now expanded reasons to support them because you have to do a demonstration or an actual injection, then we would have to review again these protocols and indications of where there has to be an in-person visit.
Great. Thanks, Stephanie. I'll let you two maybe continue in the chat if there's more kind of back and forth or further questions, but thank you so much for your presentation. Our second research presentation for today is from KADESHA James. Kay, I'll just let you get your slides up on the screen while I introduce you. Kay completed her Master of Science in Pharmaceutical Sciences at the University of Toronto under the supervision of Dr. Sarah Gilcher. During her master's, she was a student trainee in the Ontario Health System Performance Network and the Ontario Drug Policy Research Network. Her thesis explored the experiences of medication self-management in community dwelling persons, and she's currently working as a medical editor. Welcome, Kay. Take it from here.
Thank you so much, Annalise. You can hear me, you can see me. And my slides are up, correct?
Yeah, looks great.
All right, thank you so much. So good afternoon, everyone. I'm happy to present this study to you on behalf of my team with Dr. Sarah Gilcher's lab from the U of T Faculty of Pharmacy. We delved into understanding medication self-management through concept mapping methodology. We have no conflicts to disclose. And the project was funded by the U of T Faculty of Pharmacy, but study results and interpretations are our own. So we'll get started with background. We pursue the topic of medication self-management because a significant number of people worldwide take medication each day to manage their health. In 2020 alone, over 750 million prescriptions were dispensed in Canadian retail pharmacies. And that doesn't include over-the-counter medications or natural health products that many people are also taking regularly. With so many people taking medications, it's important to understand how their experiences to center the individual in the way that care is delivered and how outcomes are assessed. As per the theme of today's summit presentations, hearing what patients need is critical. The problem is that there is still limited understanding of how people manage their daily medications, because existing research tends to either, one, focus on self-managing chronic health conditions, but minimize the role of medications, or two, focus on adherence to medications, but minimize the complexity of the influencing factors in patient perceptions. And so the aim of our study was to contribute to this missing piece in the middle and understand medication management through a holistic self-management lens. Our research question was, what can persons with chronic medication experience contribute to our understanding of medication self-management? And our objectives explored what mattered to individuals related to their medication, what factors they perceived as most important and feasible, and how those perceptions of importance and feasibility varied by some of their personal characteristics. To achieve those objectives, we used concept mapping methodology. Concept mapping is a mixed methods participatory approach with 3 stages. Stage 1 was brainstorming, where participants in group discussions responded to the question, what matters to you about medications in your everyday life? Following a process of statement synthesis, stage 2, sorting and rating took place, where participants sorted statements into groups based on how they thought they were similar, and then rated those statements on dimensions of importance and feasibility. Then different map options were created to present to participants in stage 3, and I'll talk about this process later in my presentation. And lastly, one last group discussion took place in stage 3, where participants reviewed maps and reached consensus on one final visual representation of the statements and their relationships. They also named the clusters on the map. To be eligible for our study, participants were adults living in the community with recent long-term experience taking prescription medications, over-the-counter medications, or natural health products on a daily basis. So here's a summary of who our participants were. They ended up being mostly younger women. Most had at least 3 years or more experience taking daily medications. Most of them took 1 to 2 medications daily, and most were living with 1 or 2 chronic medical conditions. So following brainstorming, participants generated 100 statements, over 1,000 statements, during group discussions that we then consolidated down to a simplified list of 94 unique ones. So themes on this slide are just a small sample of the topics that came up during our group discussions. One being effectiveness, participants being concerned with their medications working and working well. Decision-making, they wanted adequate information to make decisions about medications and the right people to consult. They wanted to be able to effectively communicate with healthcare providers, and they also wanted to receive social support and mitigate negative social experiences. And so we found that statements in our study extended some of the previous self-management research that we explored by providing more medication-specific priorities. So now I'll share the results of the rating task with you. The main takeaway from the rating activity is that overall statements were rated highly on both dimensions of importance and feasibility. And relatively few statements were rated below a 4, which was an average or neutral on our 7-point scales. For importance, the highest rated statement was a medication is effective, and the lowest rated statement was related to accessing medication peer support groups. For feasibility, the highest rated statement was I can take my medication at home. And the statements rated as least feasible with similar means were about the ability to consult with more than one healthcare provider and also to access one's own electronic health record. Now I'll present the results of the sorting task and explain how we create the maps. So what's pictured here is called a point map. And this is the result after we asked participants to group together statements they thought were similar. Each numbered point represents one of the 94 final statements. And to understand how this map is made, you could imagine that you were trying to draw a map of Ontario. And you knew the relative distances between the cities, but you didn't know how they were situated geographically. You could take those relative distances and draw the map that creates the best estimate of what the province really looks like. And so for concept mapping, the relative distances between statements are calculated based on how many times the statements are sorted together. So statements that were often sorted together are close together, and statements that were not often sorted together are farther apart. And so this analysis is repeated until a map of the relative locations is created. Following this point map, we're then able to review different clustering arrangements of the statements. So this is the final result of stage 3 of our study, a cluster map. A cluster map draws boundaries around groups of statements to create a cluster, which is a group of statements with related themes. And so during a final mapping session with participants, we facilitated group discussion where participants got to review statements and potential clusters, regroup them as they saw fit conceptually, and then name the clusters as you see here on this slide. We ended up with 9 clusters in total named by participants. So once those clusters were finalized, we could then look at the rating results in the context of the clusters. And this visual here shows a comparison of statements' importance versus their feasibility ratings. And so the green box in the upper right-hand corner is called the go zone, which highlights statements that were rated above average on both importance and feasibility. And so statements and clusters within this zone can be interpreted as the most actionable statements from participants' perspective. And so our go zone, green zone, contained mostly statements from cluster 1, which was titled Researching and Becoming Educated About Medications, and cluster 3, which was titled by participants as Effectiveness of Medication. And there was also the highest rated statement, which was related to safety of medications and them being tested and approved by the appropriate regulating bodies. And so the least actionable statements, according to participants, were related to receiving information about medications from their personal networks and also about being able to seek out opinions from more than one healthcare provider. So thinking now about our results in the context of our original objectives, we had 3 key findings. One being that participants generated statements that complemented and extended existing research about how people manage their health by presenting medication-specific priorities that could be perceived as actionable and inform interventions. Second, statements were rated generally quite highly on both dimensions of importance and feasibility. And lastly, through some other analysis that we did, we found that rating correlations across participants with different characteristics were actually quite strong, such as those with fewer or more number of medical conditions. And so they did generally agree upon what they perceived as most important and feasible related to their medications. And so to conclude, I have 2 key messages. One being that our participants were actively engaged during our group discussions, suggesting that medication experiences were a big part of their lives. Even though our study demographic ended up being younger participants with relatively fewer medical conditions than may be traditionally included on studies in this topic, there is still great value in exploring their experiences because they had a lot of rich data to share. And lastly, our results suggest that we do need to take a more holistic approach when thinking about medications in order to move beyond just the concept of adherence. And that if really our goal is to provide good and person-centered medication education, prescribing, or counseling, there's great value in understanding lived experiences with medications from a more holistic self-management lens. So to follow up on this, next on the horizon for the Gilsher Lab is to advance some of this work and build off some other work with neurological populations to develop and validate a patient-reported outcome measure on medication-related quality of life. And so I'd like to close by saying a big thank you to the entire research team listed on the slide here. And as well, thank you all for listening. And I'm happy to take your questions and discuss.
Thanks, Kay. Thanks so much for providing that overview of your master's work, and nice to hear that it'll be continuing well and beyond to other patient populations and other groups and members of your team. I'll just open it up to questions from the audience, but maybe from my perspective, I think thanks for the overview of the concept and cluster mapping. I think that's a fairly novel method that we actually don't hear about too often. So it's really nice to learn about that from you today. Curious if you could just speak a little bit more kind of about how you landed on it and in what other areas of pharmacy practice research or health services research that method has been used before. And I think some of the benefits of using it and perhaps some of the gaps that result from using that method.
That's a great question. Concept mapping, it's often used in a lot of planning and evaluation type projects, most often, just because the results can be so actionable depending on what stakeholder group you are engaging, right? At the end, you can get what's rated most highly on importance and feasibility according to whatever group you're working with. So it can be a great stepping stone to what's next. So a lot of planning and evaluation type projects use concept mapping. And so in other health research fields, in education, in psychology, but in pharmacy and pharmacy practice, I think that planning and evaluating possibly new interventions would be a great way to fold in concept mapping methodology. And in terms of drawbacks and advantages, I think that having participants involved in each stage of the study is really crucial because they're there at brainstorming and then they're able to see the results of brainstorming when they sort and rate because they contributed to the statements. And then at the end, when they're involved in mapping, they can arrange those statements that they previously sorted and rated. A subset of them will come back for that. So I think one of the biggest advantages is having that involvement in each stage. And one of the drawbacks could be you really have to evaluate for yourself as a research team whether concept mapping or maybe a more traditional qualitative method is what you might really need. So there's going to be differences between concept mapping and, say, focus groups. So if you're going for a little bit more depth of narrative from your participants, you might want to consider something else since concept mapping will sort of aggregate everybody's responses together.
That's great. Thanks so much. Yeah, and very interesting just to learn about the cluster mapping as well. I think just seeing kind of the shapes take place with those dots must be really rewarding and nice that it's driven from patients themselves.
Yeah, it was pretty cool.
Fantastic. Question from Liz online. Do you think old populations would put as much priority on self-education, or do you think that they would have more trust in healthcare providers?
That's an interesting question. Thank you, Liz. Well, it was tough to evaluate in our study because, as you saw, most of our population ended up being younger. For a little bit of context, we did this study in early to mid 2020, right at the start and the ramp up of the pandemic, where a lot of this type of research moved online. And so this study was done exclusively online and recruited for online. And so reaching some of the older population might have been a bit more difficult for us since, to come across our study materials, you had to be online already. So do I think that they would have had more trust in healthcare providers and potentially less focus on education? I guess it depends on what you consider as sources of education about medication. So healthcare providers can be a source of gathering resources and seeking out education about medications, not just, looking for things online. So I guess it would be, if I were to kind of ponder this or come up with something, it would be interesting to see if different sources of information might be rated differently by different age groups.
Great, thanks for that, Kay. In the name of time, I will let anyone else follow up more directly with you via the chat box and or otherwise. But thank you so much for sharing your research with us today.
Thank you. And I'll say quickly that the study has been published in full, so anyone can feel free to just Google search the title of my presentation and you can find the full publication.
Fantastic. Thank you. That's always a nice output once you can share that with everyone too.
Yeah.
Congrats.
Thank you.
Fantastic. Okay, so I'm going to turn us now to our third research presentation of the day. Sophie and Tonya, I'll just ask you to put your slides up while I introduce the two of you. And welcome. So Sophie Kitchen is an epidemiologist with the Ontario Drug Policy Research Network and ISIS in Toronto, Ontario. She holds a Master of Science from the School of Population and Public Health at the University of British Columbia and a bachelor's degree in chemistry from Williams College. Sophie's research interests include examining the impact of policy interventions on prescription drug and health services utilization. TONYA Campbell is a research program manager with the Ontario Drug Policy Research Network. She holds a Master of Public Health and Epidemiology from the Dalla Lana School of Public Health here at U of T. TONYA's research interests include using diverse data sources to understand inequities in health, well-being, and access to health services. Welcome to you both, and I'll let you get started.
Thank you so much. Can everyone hear us or me and see our slides?
Yeah, I can hear you, and yep, the slides look great.
Awesome. So thank you for the introduction. My name is Sophie. I'm an epidemiologist with the Ontario Drug Policy Research Network, and I'm presenting today.
And I'm Tonya. I'm the research program manager with the Ontario Drug Policy Research Network based at Unity Health Toronto.
And our presentation will be looking at the impact of the COVID-19 pandemic on the provision of opioid agonist therapy take-home doses in Ontario. So we'd like to begin by acknowledging the Indigenous people of the land that we're on today. Today I'm residing in Toronto, the traditional territory of many nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse Inuit and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 of the Mississaugas of the Credit. We have no affiliations to declare. However, one of the collaborators on our research study was an author of the OAT guidance document that is evaluated in this presentation. So, opioid agonist therapy with methadone or buprenorphine naloxone is a first-line treatment option for people with opioid use disorder. And continuous use has been associated with lower rates of opioid overdose and death. However, current initiation and retention with OAT is very low. Only around a third of people with opioid use disorder ever start OAT, and among those who do start, less than half remain in treatment for 6 months. There's many reasons why OAT initiation and retention rates are so low. One reason is because of strict programmatic requirements, which require patients to visit the pharmacy daily for supervised dosing of OAT. The emergence of the COVID-19 pandemic and associated public health restrictions raised concerns around further barriers to accessing OAT, and therefore a new guidance was created that recommended clinicians to increase the number of take-home doses provided to people receiving OAT. A take-home dose, sometimes referred to as a carry, is a dose of OAT that patients can take at home and therefore can lessen the need for face-to-face contact between clinicians and patients. So the objective of our study was to look at the impact of the COVID-19 pandemic and changes in guidance to OAT on trends in take-home doses of methadone and buprenorphine naloxone.
Okay, so I'm going to talk about the methods that we used to conduct this study. So we obtained the data for this study from ICS, and we specifically used the narcotics monitoring system, which is a database that captures all prescriptions for controlled substances, such as opioids, that are dispensed from community pharmacies in Ontario, regardless of the payer for the prescription. And so we linked the dispensed opioid agonist therapy prescriptions to the registered persons database to obtain sociodemographic characteristics, such as sex and location of residence, for all people who were dispensed OAT. And all analyses were conducted at ICS. So for this study, we used a repeated cross-sectional design in which we extracted all prescriptions for methadone and the combination product buprenorphine naloxone, which are the predominant forms of OAT used in Ontario, that were dispensed between June 25th of 2019 and November 30th of 2020. We divided the study period into weekly time intervals, and we further divided that into a pre-COVID period and a COVID period. So the pre-COVID period lasted from June 25th of 2019 to March 16th of 2020. And the COVID period lasted from March 17th of 2020, which was the date that the state of emergency was declared in Ontario due to COVID, to November 30th of 2020. And that was the latest date of data available we had at the time that we conducted the study. So for each week of the study period, we calculated the percentage of OAT recipients that were dispensed each take-home dose regimen. And we did this separately for methadone and buprenorphine naloxone because we wanted to look at trends in the two medications separately. So for each prescription dispensed, the number of take-home doses provided was calculated as one less than the total day supply on the prescription. For methadone, we categorized take-home doses as 0, so no take-home doses, which is daily dispensed treatment. 1 to 6, so less than a week of take-home doses, 7 to 13, so more than 1 week of take-home doses, but less than 2 weeks, and then 14 or more, so 2 or more weeks of take-home doses. And we repeated this process for buprenorphine naloxone with the addition of a 28-day or more category, and we were able to do that because there are more people in that category for buprenorphine naloxone than there were for methadone. And so for each type of OAT, the percentage of recipients dispensed each category of take-home doses was calculated both overall and stratified by sex, urban versus rural region of residence, and for methadone only, also by dose, so low versus high dose. So our outcome was the weekly percentage of people dispensed each category of take-home doses separately for buprenorphine naloxone and methadone, as I mentioned in the previous slide. And for our analysis, we ran ARIMA models, which are time series models that are used to examine changes in trends over time and the impact of interventions on trends. And so we used a step transfer function fit to the week of March 17th, 2020, that represented our intervention. So the state of emergency declaration and the release of the revised OAT guidance. And so the objective here was to determine whether there were significant changes in the percentage of people dispensed each category of take-home doses after the intervention. Okay, so these are the results. So along with these are the results for methadone specifically. So for along the x-axis is time, so week of the study period, and then along the y-axis is the percentage of people dispensed methadone. The trend lines represent the percentage of people dispensed each take-home dose category. The dotted line is the intervention, so the state of emergency declaration and the change in guidance for dispensing OAT that was released a few days after. And what we can see here is that the most common take-home dosing regimen was 1 to 6 take-home doses, so less than a week, and the least common was 14 or more take-home doses, so two weeks or more. And what the model is looking at is basically the level change in the trend lines right after the intervention. And so what this graph is showing us is that there was a small decrease in the percentage of people dispensed 1 to 6 take-home doses and in the percentage that were receiving daily dispensed treatment, so no take-home doses. And there were corresponding small increases in the percentage of people dispensed longer take-home doses. However, again, these changes were small, and actually what we saw is that towards the end of the study period, so towards the second wave of the pandemic, the take-home dose patterns started to revert back to like the pre-COVID trends. So the changes that we saw weren't sustained. And for methadone, an average of 30% of people continued to receive daily dispensed treatment during the pandemic. So that means they had to go to the pharmacy every day. And there were no differences in the results by stratification. So these are the results for buprenorphine naloxone. So similar to methadone, we can see that the most common dispensing regimen was 1 to 6 take-home doses, and the least common was 28 or more, so a month or more of take-home doses. And similar to methadone, again, we can see that there was a small decrease in the percentage of people dispensed 1 to 6 take-home doses right after the intervention, and also a small decrease in the percentage receiving daily dispensed treatment. There were also small increases in the percentage receiving longer take-home dose categories. However, again, similar to methadone, the changes weren't sustained because we can see them starting to go back to the pre-COVID trends or patterns towards the end of the study period. And for buprenorphine naloxone, approximately 18% of people continued to receive daily dispensed treatment during the pandemic. And again, similar to methadone, there were no differences in these results by stratification.
So our findings suggest that clinical practice shifted early to increase the duration of take-home doses supplied to help prevent barriers to accessing OAT during the COVID-19 pandemic. The greater flexibility in the provision of OAT was more concentrated among individuals who were already receiving take-home doses, and many patients continued to receive daily dispensed therapy during the pandemic. There may have been an unequal distribution because some clinicians may not have thought some of their patients were eligible for increased take-home doses, or some clinicians may not have been aware of the change in guidance. And we also found that dispensing trends reverted back to pre-pandemic levels, suggesting that more comprehensive strategies may be required to ensure equitable access to take-home dosing. Our study used a large and comprehensive database that captured all prescriptions for methadone and buprenorphine in Ontario over our study period. However, we also had some limitations to our study. We were not able to assess rates of people entering and exiting treatment during the study period, and how that may have differed by the dosing regimen. However, the number of people actively being treated with methadone and buprenorphine was relatively stable over the study period, which indicates that patterns of people initiating and discontinuing did not change substantially over the study period. We were also unable to look at the longer-term impacts of the COVID-19 guidance, including whether the subsequent waves of COVID-19 resulted in a resurgence of longer take-home doses. Finally, due to data limitations, we were unable to assess the impact of other factors, including opioid use disorder severity, urine drug screens, race or ethnicity, housing status, or a history of incarceration, on how that may have influenced clinicians' decision to prescribe take-home doses. So, in conclusion, the continuous use of opioid agonist therapy is a very important factor that reduces the risk of opioid-related overdose and death. We found that during the COVID-19 pandemic and the associated change in guidance resulted in a small increase in longer take-home doses for OAT. However, given the changes were small, strategies to improve retention in OAT and ensure equitable access to take-home dosing should continue. Future work is also needed to better understand the long-term impacts of take-home doses on patient retention and outcomes. Our team has conducted a few follow-up studies that look at discontinuation and outcomes, but longer-term research is needed. It will also be important to study the patient and clinician level factors that resulted in changes to take-home doses of opioid agonist therapy. We're grateful to the funders and data providers of the study that are listed here. And thank you very much. Please let us know if you have any questions. And this study has also been published, so you can find it at this link or by Googling it, I guess.
Thank you both so much. Sorry, I was trying to unmute myself there. Thank you so much, and feel free to put your publication link in the chat as well. I should have said that to Kay, but happy for that to be circulated as well. I think that's a major outcome that we're hoping for the summit. We'll allow questions to trickle in, or you can save them to follow up with Sophie and Tonya after. I guess thoughts about some of the data and analysis. During the beginning of the pandemic, the first few months, there were fairly significant supply chain issues affecting a variety of medications all across Canada. Do you think that was potentially a confounding factor? that perhaps disrupted some of your, data analysis and findings, and then kind of accounted for that reversal that you talked about later on in the pandemic and kind of where we are now?
Try to answer this, but Tonya, feel free to jump in. We did hear about some supply chain issues with other forms of opioid agonist therapy during the pandemic. I think Cadian was one, but I didn't hear any supply chain issues with methadone or buprenorphine naloxone.
Yeah, I would agree with exactly what Sophie said.
Great, thank you. Quick and easy answer then. Question from Anne. Always so fascinating that emergencies stimulate greater acceptance of professional judgment, but it doesn't necessarily stick. Are you aware of any ongoing plans for research other than what you mentioned? It seems like there's a lot to learn.
Yeah, that's a great point. As Sophie mentioned, I think there's some room for research to look at the longer term impacts of these changes on retention. And also, I think our study period kind of ended like not even well into the second wave of the pandemic. So I think another study would be helpful to look at whether the reversion we noted to the pre-pandemic patterns continued, or whether as we kind of went through the second wave and the third wave, if we saw kind of increased dispensing of longer take-home doses. So I think that's kind of what I would like to see for future studies. Sophie, do you have what would you like to add?
Yeah, I think that's all true. I think what was really interesting while we were conducting this study was there were changes to not only OAT guidance, but to the 2011 methadone dispensing guidelines. And so it will be really interesting to see how the pandemic may have accelerated a shift towards dispensing more take-home doses in the future.
Great, fantastic. Thank you both so much. I will let others follow up with you in the chat, but thank you again. So I will now turn it to our final research presentation of the day. SADAF, please feel free to get your slides up on the screen whenever you're ready. And I'll introduce you as well. SADAF FAISAL is a licensed pharmacist in Ontario with over 10 years of experience in community, long-term, and primary care settings. SADAF received her Bachelor of Pharmacy from the University of Karachi in Pakistan and completed hospital pharmacy residency. She's also a board-certified geriatric pharmacist through the Board of Pharmacy Specialties in the United States of America. She currently practices as a clinical pharmacist at the Thames Valley Family Health Team in London, Ontario. She's pursuing her PhD under the supervision of Dr. Tejal Patel at the University of Waterloo, and her PhD research is focused on medication use problems in various patient populations, including older adults and people with chronic disease. She also has a particular emphasis on medication management and adherence issues through the use of various innovative technologies. Her PhD thesis project has received funding from Age Well and the Canadian Frailty Network. SADAF, over to you. Oh, I think you might just be on mute. I can see your slides, but we can't hear you.
I was. Sorry.
No problem.
Can you hear me?
Yes, now we can.
Thank you so much. Thank you for the introduction, Annalise. Good afternoon, everyone. I also wanted to share good news that I completed my PhD last month, so I'm officially done. I will be presenting today on behalf of my research team a study about in-home medication management by older adults with chronic diseases. So I have nothing to disclose. My supervisor, Dr. Patel, is involved in research grant and funding from industry. So as we age, we tend to accumulate chronic diseases, and about 1/3 of Canadian seniors reported to have 2 or more chronic diseases. And medications are one of the most important aspects of chronic disease management and prevention. Somebody just said right before me how many prescriptions we are filling in a year. So that just tells us that how much medication usage is being done for people with chronic disease management. Now, In 2016, 1 in 4 Canadian seniors were prescribed more than 10 drugs. And as the number of diseases increases, the number of medications also increase, which lead to use of complex therapy regimens. These complex regimens may include multiple medications with variable dosing forms and more than once daily administration, which can be a daunting task to manage on an everyday basis. When you take an antibiotic, how many of you actually remember to take 3 times daily? And imagine if you need to manage 6 or 7 medications multiple times during the day. Now, just imagine that if an older adult has to manage complex regimen on a regular basis, how would they feel or how would they deal with that? So what happened then, that patients start having heart attacks, strokes, going back and forth to emergency room and getting hospitalized. Now, not only that caused burden to our healthcare system, but patients' own quality of life goes down and their spouse and their kids, they suffered with caregiver burden. So now managing multiple medication on a regular basis is a complex process. In-home medication management refers to an individual's ability to self-administer a prescribed medication regimen. That means that medication management in a patient homes not only involve administering the right drug, the right time or appropriate duration, but also include appropriate storage and organization processes. Published research have indicated that there is significant problem exists with medication management and storage at home. Most of the studies that have been published in this regard have analyzed the medication management and storage quantitatively, which gives us a really good idea about these issues. However, there is limited information about the context of medication organization, storage, and administration in patients' home. So in order to gain a holistic insight into medication management practices within patients' home, we designed a qualitative study using modified ethnography approach to explore in-home medication intake, administration, storage, and organization processes used by older adults who live independently. Participants were eligible to participate in this study if they were 18 years of age or older, at least diagnosed with 1 chronic disease, were taking complex medication regimen, which we defined as taking 5 or more medications per day, or if taking less than 5 medications per day, taking more than once daily dosing schedule. They must self-manage their medication regularly, and they allowed us to go and visit them in their homes. We used ethnography-informed data collection methods such as participant observations and field notes along with digital photography walkabout. Digital photography walkabout is a process of taking pictures while walking around the places of interest. So we went into patients' home, we asked them to show us where do they store, organize, and administer their medications on a regular basis, and we took photographs of those areas. We also asked them if they can explain how do they process their medication management at home. We wrote detailed field notes during and after in-home visits, and then data that included the photographs, field notes, and participant observations was analyzed using conventional content analysis. So a total of 10 older adults participated in the study, where the average age was 76 years, and most of our participants were female. As expected, the average number of medications per day was 11.1, and all of them reported to have more than 3 chronic diseases. Majority of them did not have any caregiver involved in their medication management processes, and participants stored their medication in their kitchen, bathrooms, dining rooms, living rooms, bedrooms, and even in their linen closets. So let me take you all to some of my participants' homes. We found a bunch of things and we organized them into 3 major themes. So the first theme that I'm going to explain is the choice of storage location. Participants were storing medication in various locations, some of them in the bathroom, some of them hiding them in decorative boxes where no one would imagine to find a prescription vials, as you can see in the second picture in the middle. Some of them were keeping them out in the open on the dining table as they were not concerned about the privacy, and they found that this kind of management process will actually allow them to remember that they need to take their medications in the morning or in the evening after they eat their meal. Some of them were storing them with their household items. So we grouped these 3 sub-themes: impact on medication behavior, visibility of medication, and storage with other items or stored in multiple locations under choice of storage location. We found that participants had limited knowledge about the safe use and safe storage and safe administration by storing them in kitchen, close to the stoves and appliances, and high humidity areas such as close to the bathroom showers. The first photographs, you can see that a medication blister package that has a paper bag was stored in the bathroom, where a high humidity area can actually get absorbed through that paper bag and can impact the stability of medications. Some participants also stored used insulin needles in a plastic bag rather than in a sharps container for safe disposal. And they were also storing expired and discontinued products along with their regular medications, which can also impact patient safety. The third theme that we identify in the study was that participants had developed some kind of routine or system for the administration of their daily medications, which emerged as our third theme. These different systems to manage medication included the use of adherence aids, such as pharmacy-prepared blister packages or patient-prepared dosage boxes, or they were following some kind of routine to administer their medication on a regular basis, such as keeping an empty pharmacy vial on the kitchen counter as a reminder, or making their calendar to check non-blister pack medications so they cannot forget that. So by gathering all this information, we decided to make an informational diagram about in-home medication management. This study highlighted that in-home medication management is a significant part of everyday life for older adults with chronic diseases. Patients develop specific routines and strategies that are personally meaningful to them, and they store their medication in different locations depending on the multiple factors, such as reminders or cues for timely intake, ease of access, or privacy. Now, the choice of location to store and administer medication can drive their medication intake behavior, but also keep in mind that storing medication to the locations that are close to kitchen stoves or high humidity areas can also impact medication stability. Also, keeping expired and discontinued medication along with regular medications can impact the safe use of medications. People with chronic diseases have different systems. They either follow or they use some kind of adherence aids to manage their medications. So by gathering all this information, we created this informational diagram to frame the approach to in-home medication management in patients managing long-term therapies. This outlined the key aspects of medication storage and management in patients' home and factors that can impact the medication management processes. We hope that healthcare providers, specifically pharmacists, can use this to initiate the dialogue with their patients about their in-home medication management. We may tell our patients to store the medications in a cool and dry place, but be very specific about what does a cool and dry place mean. Also identify patients if the privacy of their medication is an important aspect, and that is something that we need to discuss with them while we are counseling them about their medications. Like any other study, we had certain strengths and limitations. We used comprehensive methods of digital photography walkabouts, observational protocols, and field notes, which provided us with detailed information on in-home medication management. The data was analyzed independently, and we had multiple discussions among team members that provided rigor to our study. However, there were certain limitations. For example, participants may have altered the storage locations before we visited them in their home. But when we visited them, it didn't seem like it, because we did find places where we were not expecting that people will store their medications. Our study had a small sample size, so we were not able to perform a subgroup analysis. So future studies should have a larger sample size. The take-home message from this study is that in-home medication management is dependent on storage location, conditions, and organization systems. The choice of that location may impact a patient's medication intake behavior based on the visibility and co-storage with other items. And knowledge about appropriate storage of medication can very well impact stability and safety of medication use. Thank you so much for listening. I would like to thank all the participants for their time and feedback. A big thank you to the research team, our funders, and feel free to contact us if you have any questions, and I'm happy to take any questions.
Great, thank you, SADAF. Thank you for your presentation, and also congratulations on defending your thesis. I think that's really exciting, and didn't have it in your bio, but that's a nice thing for you to be able to share. Thank you as well for the photos in your presentation. I think that's just very illuminating to have such clear examples of, you know, where things might go a little bit astray with patients managing their medications at home. Maybe we'll let questions trickle in if there are any from online, but perhaps more personally, what's next for you after finishing your PhD?
Right now, I'm just taking some time off.
Good, that's the right answer.
The last 2 years have been really crazy.
Congratulations, very well deserved. Happy to hear that. Quick question from Heather and then another one from Anne. I'll start with Heather's. Really interesting methods used here, which I think give a real insight into patients' medication management than interview data alone. Can you elaborate a little on how the data from the various data collection methods were triangulated and analyzed?
Thank you so much, Heather. That's a really good question. So we use more than one method to collect the data. That gives us the method triangulation that we did. So we not only took the pictures, we also verbally asked people to provide us a walk about how do they manage their medication, and we recorded all that information. Then researchers wrote notes during the visit, and also after we left patients home, we wrote reflective notes. And when we were analyzing the data, we actually match each picture with that particular observational protocol and the field notes, so we don't miss anything. We also use more than one researcher, so we used multiple researchers during the home visit. So if one researcher was skipping something or forget to ask, the other researcher jumped in. That also give us a little bit more detailed insight about what were they saying. We also observed them during the home visit, so we just didn't kind of ask them questions and noted it. We also observed how they were doing during that. Were they hesitant about sharing something? We asked them why were they storing the medication in a particular location. That was our big question, because we wanted to find out the context of the whole medication storage and organization in patients' home. Does that answer your question? Okay.
Thanks for that. Yeah, no, thanks, SADAF. That's fantastic. 2 more questions. So Anne's question is, did fear of COVID affect patients letting you into their homes at all, in your opinion?
Well, I was very lucky, Anne. We actually, so this study was a part of the biggest study. So my big PhD project, it was a part of that study. And I was very lucky that I finished this study before I started my second one. So my data collection was right done in January. And I think it was February or March when we had the pandemic and we had put a stop on in-person research. So I was very lucky that we finished all our in-home visits right before the COVID started.
Definitely very fortunate, for sure, but also helpful in your case. From Kay, very interesting work. Congratulations on your PhD. She is curious about what your participants said regarding how they store or take medications when they're not at home. Do they try and schedule doses only to be at home? And if so, do they consult with their healthcare provider about tailoring their dosing times?
So that's a really good question, Kay. So yes, they do. We did ask them that when you are leaving your house, how do you manage your medication? So a lot of them did explain that if they have a doctor appointment or if they have to end up going somewhere, they do, if they are using a doside box, they keep the doside bags in their bag. The picture that I showed you about the bathroom storage where the blister pack was hanging on the bathroom wall, that particular participant actually tear up that piece for their morning doses or afternoon doses, and they keep them in their purse when they are leaving the home. We did not ask them about if they are consulting their healthcare provider about tailoring the dosing time, which is a really good question. And I think that is something that we should look into that, and that would tell us how their relationship is with their healthcare provider. But a lot of them, they do take time to, they do take their doses with them when they leave the house for traveling purposes or for going out for lunches.
Wonderful. Thanks, SADAF. You're tackling many of these questions really well. The last question is just from Jeff. He asks, any plans to research adherence for patients using different storage methods? Could the next step be a quantitative survey or?
That's a good question. You know what, to be very honest, when I was doing the background research for my project, there was so much quantitative work done related to in-home medication storage and organization. I really want to do more qualitative work. Like, I know the numbers look fascinated, and I really like to have like a big sample size where I can have like, you know, a lot of patients and I can tell what percentage are storing where. I'm more kind of a qualitative researcher. I enjoy asking why rather than what and how. And so I'm kind of more interested in doing more qualitative work, where we can see like in more detailed with people, like why are they doing certain things in their homes related to their medication management. But yeah, quantitative survey would be good too. Maybe I can do that too.
Or maybe the next lucky PhD student will take on that component.
Yeah.
We'll see. Thank you so much, SADAF, for sharing your research with us. And congratulations again.
Thank you. Thank you so much for providing the platform. This is my 3rd year in a row at Open, so I'm really excited.
Oh, fantastic. So thanks everyone, for those that are still joining us online. The last 10 or 15 minutes of our session today are going to break out into small groups. So I'll be splitting us up into breakout rooms, probably with about 5 people. I've just popped into the chat box. Each of your groups will have a facilitator who will introduce themselves, and really just want to use this time for opportunities to discuss as a group, share resources, etc. So I'll just get those breakout rooms set up now, and then we will come back at about 2:55 Eastern time, and then Zubin and I will wrap up for the day.
So first of all, thank you all very much to our speakers and our presenters, especially our keynote speakers, ZAHAVA and John. Thank you to all of you who attended and participated and stayed until the end to share your thoughts with your colleagues. If you are interested, and I hope you will be, in more information on the Ontario Pharmacy Evidence Network, Open, here are some links that you might be interested in, and please do consider joining our mailing list, also listed here, so you receive up-to-date notifications of events such as this. We'd also encourage you to consider finding out more about the Center for Practice Excellence, our co-host for today's events. Please feel free to contact Annalise directly through the email or check out our website and mailing list at the links associated here. Thank you all again very much for attending today, but a particular thanks to Annalise for organizing and hosting today's events. As you can imagine, this is a considerable amount of work, and we sincerely appreciate all that you do for the open community, Annalise. We have one more event coming up in a couple of weeks. If you have not yet registered for it, please do, and please bring a friend. Great to see people turning their cameras on, especially during these kind of pandemic times continuing. So wonderful to see everybody. Thanks again for attending, and have a great day. Bye-bye, everybody.